Welcome to your online anaphylaxis training presentation delivered to you by Compass. Throughout this presentation, our objective is to improve and update your knowledge of managing severe allergies, including early recognition of symptoms, allergen avoidance, and crisis management. There will also be a visual demonstration of how to administer the different types of adrenaline injectors. To put this into context, over 1 in 1,000 people in England have experienced anaphylaxis at some point in their lives. There are approximately 20 deaths from anaphylaxis reported each year in the UK, although it is thought that this may be underestimated. Anaphylaxis is a severe and potentially life-threatening systemic allergic reaction. By systemic, we mean that multiple systems in the body become affected and may start to shut down. Systems in the body which could be affected include the airways, the heart circulation, the gut, and the skin. Anaphylaxis is at the extreme end of the allergy spectrum and can be potentially life-threatening. Therefore, anaphylactic reactions always require an immediate emergency response. The whole body is usually affected within minutes of exposure to the food or substance that an individual is allergic to. However, it is important to remember that it can also take place within seconds or on rare occasions even later after several hours have passed. Similarly, symptoms can also reoccur several hours after treatment. This is why it is so important that if a child is exposed to an allergen whilst in your care, you inform their parent or carer of the details of their exposure and any medication that was administered so that they continue to monitor their child when they go home. Anaphylaxis involves one or both of the two following features. Anaphylaxis can cause respiratory difficulty, including swelling of the airway or exacerbation of asthma. Anaphylaxis can also cause hypertension, which can lead to fainting, collapse, or even loss of consciousness. So what actually happens when someone has an anaphylactic reaction? When someone is exposed to an allergen for the first time, the body creates antibodies to attack the allergen but does not cause an allergic reaction. The next time the body comes into contact with the allergen, the antibodies present will then attack the allergen. An anaphylactic reaction is caused by the sudden release of chemical substances, including histamine, from cells in the body into the blood and tissues. The release is triggered by the reaction between the allergic antibodies and the allergen. Therefore, it is always important to remember that it will not be the first time when the body is exposed to an allergen that a reaction will be seen. There are many signs and symptoms of anaphylaxis, and some of the most common ones are listed on the screen in front of you. You may notice generalized flushing of the skin or what resembles a little rash anywhere on the body. When histamine is released, the tiny blood vessels known as capillaries leak fluid and the fluid accumulates in the skin and causes a rash. Hives in children and young people from ethnic backgrounds may look different compared with other skin types. While hives are still raised and itchy, they may appear red or purple-like. However, in many cases the hives may not show any distinct color or may be similar in color to the surrounding skin. This can make them harder to recognize. Children and young people may also experience a sense of impending doom. This sounds quite dramatic, but it just may be a feeling that something bad is going to happen to them or just that something doesn't feel quite right. You may also notice swelling of their throat and mouth. It's important to remember that whatever swelling you're seeing around their lips or mouth will also be happening on the inside of their airway. This may result in them finding it difficult to breathe. A difficulty in swallowing or speaking may also indicate that the individual is having difficulty with breathing. If a child is experiencing difficulties in breathing, you may notice that their shoulders go up and down in a more exaggerated movement when they breathe in and out. You may also notice these breathing movements become faster or slower in younger children. You may also see their nostrils flaring as they're trying to get more oxygen into their body. If a child or young person's lips become blue or white, this means that they may be struggling to breathe and cannot get enough oxygen into their body. If a child has asthma, their asthma may become exacerbated and you may hear them wheezing. Some children may also experience abdominal pain, nausea, or vomiting. They may also experience a sudden feeling of weakness caused by a drop in blood pressure. If this happens, the person may become faint, dizzy, or in the case of a child, they may become floppy. This may lead to collapse, unconsciousness, and on rare occasions can even be fatal. It's also important to remember that each child or young person will experience their own signs and symptoms. In younger children who may not be able to verbalize how they're feeling, they may go unusually quiet and sit down somewhere on their own. As a service, we will always try to include a child or young person's specific signs or symptoms on their healthcare plan and in a manner that is familiar to them. For example, the service once wrote a healthcare plan for a child who described food as tasting spicy when it gave them an allergic reaction, as that is how they identified and verbalized that they were having a reaction. It's important that school staff around the child are familiar with their healthcare plan and the child's own description of their reaction, so they will be able to act appropriately if the child was to have an anaphylactic reaction. On this slide are examples of how anaphylaxis may visually present itself. As you can see, Picture 1 and 2 are an example of widespread hives and what resembles nettle rash. As we mentioned earlier, be aware that children and young people with different skin types can present in different, less distinct ways, making it harder to recognize. Pictures 3 and 4 are an example of swelling of the lips and mouth. Remember, the swelling that you see on the outside will also be happening on the inside to their airway, which can have an impact on their breathing. As you can clearly see image 4, the child's lips have started to turn white, which indicates that they are not breathing adequately to receive enough oxygen in their body. Substances that cause allergic or anaphylactic reactions are called allergens. At this time, food triggers are still the most common causes of anaphylactic reactions. It's also important to remember that allergens can also be airborne and therefore do not necessarily have to be ingested or come into contact with the skin to cause a reaction. As a service, we will always make sure the root of how the allergen affects the young person is reflected in their healthcare plan. Peanuts and tree nuts are some of the common causes of allergens. If a child is allergic to peanuts, it does not necessarily mean that they are also allergic to tree nuts and vice versa. Tree nuts are in a different botanical category to peanuts and include almonds, hazelnuts, walnuts, cashew nuts, pecans, Brazil nuts, pistachios, and macadamia nuts. It's important to make yourself familiar with the child or young person's healthcare plan, so have a clear knowledge of what their specific allergens are. Milk, eggs, sesame, fish and shellfish are also common allergens. Lupine, like on the screen in front of you, is also an identified allergen. Lupine is a common garden plant, and seeds from some varieties are used to make flour. As you can see on the screen in front of you, latex says it's linked with kiwi. This is because allergic compounds that are present in latex are similar to the compounds in certain tree pollens. Fruits, nuts and vegetables, including kiwis, penicillin, wasps and bee stings are also common allergens. It will be difficult in a school to avoid potential wasps and bees, but it's about having an awareness that if a child or young person does go outside, there may be a risk to them. On the screen in front of you are the 3 treatments used in the event of an anaphylactic reaction. The adrenaline pen is the key treatment in dealing with anaphylaxis quickly. It works on the cardiovascular system and the respiratory system to stop fatal effects of an anaphylactic shock. It does this by very quickly making the blood vessels smaller, relaxing the muscles in the lungs to improve breathing, reduces swelling, and it also stimulates the heart. The adrenaline pen should only ever be injected into the outer thigh and should never be injected in the buttocks. In a moment, we will go through the details of the 3 available adrenaline pens, and there will also be videos demonstrating how to use each of them. The key point to remember is that you're not going to do any harm by giving the adrenaline pen to a child or young person if they are having any sort of reaction. In fact, if you are in any doubt about whether you should give the pen, it's always better to give it because the immediate response in an anaphylactic reaction is key to ensure the safety of the child or young person. Asthma inhalers may also be used to relieve breathing difficulties if the child has diagnosed asthma and there is an inhaler available to them in school. Prescribed antihistamines can also be given if the symptoms are mild. On our healthcare plans, we outline the difference between mild and severe symptoms and therefore when it is appropriate to give the antihistamine first. However, I would say that if you are in any doubt, you aren't going to do the child or young person any harm by giving the adrenaline pen when they are having a reaction. It's important to make sure that adrenaline auto-injectors are easily accessible at all times in case of an emergency situation. The medication should never be separated from the child or young person and must go wherever they go. It should not be locked in an office or at home, and there should never be just one at home and one at school. Primary school teachers may carry the emergency medication for the child or young person. However, if they are in secondary school, the individual must carry their own adrenaline auto-injector. It is also a good idea for the child or young person's friends to be taught how to use the medication using a trainer pen that an individual can be given at a clinic. This could help in an emergency if no staff are in the area to assist with any storage methods. It's important to avoid extremes of temperatures, as this can affect the medication and the mechanism inside the pen. Making sure the medication is clearly labeled is important, as when writing healthcare plans we always request that parents or carers provide prescription-labeled medication to school so that it is clear to school staff when and how much of a medication to administer. We also often recommend to schools that they keep a child's healthcare plan, adrenaline pen, inhaler, and any antihistamines together in a clear box so that in an emergency situation it's easy to grab hold of and take directly to the child. We also recommend that schools check the medication they've got in school every half-term to make sure it's in date so that it's there for an emergency situation if you need it. When we think about the adrenaline pens, the first brand that often pops into the head is EpiPen. The EpiPen is one of the 3 adrenaline pens that we're going to talk about today. The EpiPen comes in 2 doses, 0.3 mg for adults and 0.15 mg to children. The EpiPen has a distinctive blue cap and an orange at the end, and that's where the rhyme comes from. Blue to the sky and orange to the thigh to help avoid confusion when administering it. The EpiPen has an 18-month shelf life. However, it is worth bearing in mind that when storing it in school, we recommend checking the expiry dates on the adrenaline pens every half-term. There's also a really good feature on the EpiPen website itself. It has an expiry alert system which parents and carers can sign up to so they can get text reminder notifications before their child's EpiPen expires. So you may find it helpful to mention this to parents or carers as well as checking the expiry date. The EpiPen itself has a clear glass window on it that enables you to check the contents of the EpiPen. Make sure that the liquid is clear and colorless. When it becomes too exposed to air or light, adrenaline deteriorates rapidly and will become pink or brown. You cannot use this medication if you notice that the liquid is unclear, colored, or contains solid particles. This is what the EpiPen looks like, blue to the sky and orange to the thigh. The instructions are displayed on the side of the pen. It's important to remember to hold the pen in the middle, ensuring any fingers or thumbs are out of the way of the ends of the pen to prevent any accidental injection into your own hand. If you do accidentally inject yourself, please seek medical attention immediately. Lift off the blue cap and push the pen into the upper quadrant of the thigh with the orange end. Hold this in place for 10 seconds and release. The orange part will then extend to cover the needle. All of the adrenaline injectors will go through clothes, but be mindful of seams and anything in pockets like the EpiPen. The Juxt pen also comes in 2 different doses, 0.3 mg for patients over 30 kg and 0.15 mg for patients between 15 to 30 kg. The Juxt pen also has a distinctive yellow cap on the end. That's where we talk about the Juxt pen being sunny side up. So when in use, the yellow side faces away from the child to avoid any confusion. It also comes with a 24-month shelf life, so it lasts a little bit longer than the EpiPen. It works in the same way as the EpiPen, as it clicks when the dose of adrenaline has been administered. This is the Juxt pen. It's very similar to the EpiPen. It has the instructions down the side to help. As a reminder, hold the Juxt pen in the middle in the same way as the EpiPen. Take off the yellow cap, sunny side up, and push and hold into the upper quadrant of thigh until you hear a clicking noise. Hold in place for 10 seconds and release. The needle is covered when the black part is extended. This is the Hamlets pen. It actually works slightly differently to the Juxt and EPI pens, as there is no safety cap on this device. When you take off section 1, you can see on the picture that it releases the needle to then be given to the child or young person. Again, it comes in 2 different doses for children and young people. However, for adults over 60 kilograms it also comes in 500 micrograms. This pen has a 30-month shelf life. Recently, There have been less and less prescriptions of the Hamlet pen being prescribed. Most children and young people will have an EpiPen or Jext pen, but you should be aware that some individuals may still have a prescription for this particular pen which is in date and usable. With this pen, it's not as clear which end the needle is going to come out of. This means it's essential that you hold it in the middle like we're going to show you in the video, just to prevent any injury to yourself. This is the Hamlet pen. As you can see, it looks different to the EpiPen and the Jext pen. It's all one color, so there's no distinction between the two ends. Hamlet does not have a safety cap, so as soon as you release the cap, the needle is exposed. The instructions are displayed on the side. Administer the Hamlet pen into the upper quadrant of the thigh. Push and hold in place for 10 seconds. Children and young people at risk of anaphylaxis who need to carry adrenaline auto-injectors should always carry them with them at all times. They should carry 2 devices with them as some individuals may require more than 1 dose of adrenaline. The device could also misfire or be used wrongly, leading to the need for a second device. They should also carry antihistamines if prescribed, an allergy action plan, and if possible they could wear a medical alert bracelet or something similar. Allergy avoidance is really the key aspect of preventing an anaphylactic reaction in the first place, so knowing the child and knowing their allergies is paramount. We will support you to write the healthcare plan so that information should be available to you. Being allergy aware and risk assessing is also important. Special occasions such as school trips, school discos, or any change in environment could introduce allergens that could become a problem for the child. Cookery lessons are also worth considering and assessing. An individual should not be excluded from cookery lessons due to an allergy as they still require their experience at school. Therefore, careful consideration should be given to avoid the child or young person coming into contact with a specific allergen that causes them an anaphylactic reaction. It's also worth letting the school kitchen know if there are individuals in school with allergies so they can be aware of the situation. Science experiments also need to be considered as this sometimes involves bringing different products or substances into the classroom. Consideration should also be given to school pets, which are now becoming more popular. Although a lot of schools do have pets that are hypoallergenic, you should be aware that they can still cause allergic reactions to some children and young people. Forest, school and outdoor activities can also harbor risks due to the exposure to tree seeds, bird feed, etc. Be mindful of this, especially in the autumn and spring seasons. To emphasize the key principles of good management, which are allergy avoidance, which we have discussed in the previous slide, and the early recognition of symptoms that we discussed earlier, we're now going to look at crisis management and what to do in the situation of an allergic reaction. So what do you do in an allergic reaction situation? Try to stay calm and alleviate any fears the child or young person may have. We can appreciate that it may also be a very stressful situation for yourself, especially if you know that you have to give a child or young person their adrenaline pen. But try to remain calm so that the individual does not panic. It's important that you call for help and clear the area. Please do not leave the child or young person on their own at any time. If you need somebody to go and get the EpiPen for you, shout for help asking that person to get the adrenaline pen and bring it back to you as soon as you are able to. Please ring 999. The operator will be able to guide you through the emergency situation. Patient positioning is also something to consider. If the child or young person looks faint or pale, raise their legs above them as you would if a child or young person was feeling faint. If they are looking red in the face or neck area, sit them upright. Pallor may be difficult to detect in dark-toned skin and may present as ashen or gray in brown-toned skin. The skin will present more yellowish in color. Refer to the child's anaphylaxis healthcare plan because this will include the specific signs and symptoms of their anaphylactic reactions to an allergen. The healthcare plan will also advise whether to use the adrenaline pen straight away or to use the antihistamine first. Giving the emergency treatment can be quite stressful, but you are not going to do them any harm by administering the adrenaline. It's much better to give it than not in an anaphylactic situation. When administering the adrenaline pen or an antihistamine, please make a note of the time it was given. You will then be able to give this information to the medical staff that arrive with the ambulance. Please remember that an adult is to stay with a child or young person at all times and monitor them closely until medical help arrives. 5 minutes after administering the first dose, if there has been no improvement or the individual starts to have another reaction, you can then administer a second dose into the other leg. If the adrenaline is given to a child or young person, either when they are sitting up or lying down, then it is important to leave them in that position. This is to prevent something called empty ventricle syndrome. This can occur within seconds if their position is changed and can at times lead to a cardiac arrest. If CPR is needed, then follow this in line with your own pediatric first aid training. It's imperative that if a child or young person has been given adrenaline that they go to hospital. They will require a minimum stay in hospital for 6 hours, as on rare occasions there can be a further late reaction. The individual will only be allowed to leave hospital when they are well enough and have had their adrenaline auto-injector replaced. They will not be allowed to go home without one. Furthermore, if you have had to give the adrenaline pen, keep hold of it so you can then pass this on to the ambulance crew so they will know the exact medication that has been administered to the child or young person. They will also be able to dispose of the adrenaline pen in a safe way. Please note that if a child or young person has had adrenaline administered, they must go to hospital and they must be taken there in an ambulance. School staff should not transport an individual to the hospital in another vehicle. They should always wait for an ambulance. Here are a few more things to consider when we say, will a supply teacher know who I am? We're thinking about any new staff into the school, making them aware of the child or young person's allergies, their signs and symptoms, and what to do in an emergency so they can offer the right support at the right time. When we say kissing can seriously damage your health, here we consider younger children. Children often share lots of things such as food and come into close contact with their peers. Whilst this interaction is lovely, we must be aware that there may be another child in that classroom with an allergy. It is important to consider that if a child has been eating peanuts and then is near another child who has an allergy, this could cause them to have an anaphylactic reaction, as they don't have to ingest the allergen and it can affect them by being airborne. As discussed earlier, indemnity insurance is something that all schools should have anyway. It protects you if you need to offer support or help to a child or young person in an emergency situation, so that should be something that is already in place. Another thing to consider is any additional training needs with additional volunteers and parents who contribute. It may be someone that works in breakfast or after school clubs if parents come into the school to help. For example, some schools have parent associations where they run school discos and school trips or have responsibility of a child or young person at any time. It's important to make them aware of the child or young person's allergen plus their signs and symptoms. It's also important to remember if you're going on school trips that the medication is taken with you, it's in date, and that you also have a copy of the child or young person's individual healthcare plan. Individual healthcare plans help to ensure that a school can effectively support pupils with medical conditions that they may have. As we have previously mentioned, we can support with completing a healthcare plan on a child or young person in partnership with a child or young person's parents or carers and school staff. However, it is the school's responsibility to ensure that the healthcare plan is updated annually. If a child has a SARSI healthcare plan provided by an allergy specialist, this will precede our healthcare plans, and they're usually in date until their next specialist appointment, which is between 12 and 24 months. It's important to keep the child or young person's own terminology of their signs and symptoms central to the healthcare plan. You can always contact us if you feel you need any support or are unsure whether a child or young person requires a healthcare plan. Schools can hold emergency inhalers in case a child has an asthma attack in school. From the 1st of October, 2017, schools were also able to have their own emergency auto-injectors. Schools can buy emergency auto-injectors without a prescription for use in an emergency situation. However, the emergency auto-injector should only be used by children who have been diagnosed with anaphylaxis and have a prescribed auto-injector. Schools need written parental consent for the use of the emergency auto-injector. There are some links below for further guidance on managing emergency auto-injectors in school. We recommend that schools carry out a medical drill to ensure that they are clear of the plan if an emergency event occurs. This will give you the opportunity to address any issues in a mock-up situation rather than in a live one. Also, in an emergency situation, don't forget to send an adult to wait for the paramedics to ensure that they can get into the building and take them directly to the child or young person. It may also be worth downloading the What 3 Words app on your mobile phone, as this is designed to allow ambulance services to identify any location within around 3 meters. This may be particularly useful if you're off the school site or attending rural school trips. If you would like any further information, advice, or guidance, the following websites may be beneficial to you. Any links and contact details that we have discussed in this presentation will be provided below this video.